Thank you. We're now going to move to this next section where we're taking some of that research evidence that's been presented to us and taking that from theory into practice. And what we're going to explore is the local and national perspective. So we've got some speakers who will be sharing with us how these different biological processes that are a result of systemic racism and discrimination that people experience. We heard there about the very important intergenerational transmission of discrimination and how that can set up even with sort of prenatal inequity, and that carries on through life. So we're going to explore that in a little bit more detail with some concrete examples of how we can acknowledge, recognize, and tackle that systemic racism and discrimination. So I'd like to introduce our first speaker, and that's Emilie Bourgeat, who's the Policy Officer for Défenseur des Droits France. Emilie.
Should we go already to the panel, maybe, or not? To sit already there?
Yes, we can do that. Depends on whether you'd like to speak from here or from there. Okay, so Emilie, please take a seat.
Yeah.
Joining us online, we have Maricarmen Cortés. She's the coordinator of CEDRE, the Fundación Secretariado Gitanos in Spain. So welcome to Maricarmen. And I also have Hans Verrept, the head of intercultural mediation and policy support unit for the Belgian Federal Public Service for Health, Food Chain Safety, and Environment here in Belgium. So we have three different perspectives that will take us through what some of these things that we heard about first, what does that mean in practice? What policies can we put in place that might address this, and how do we move from a system that emphasizes and adds on to discrimination to one that tackles it and changes it? So that's what we're going to explore. And the first person who's going to speak is I'm going to invite Emilie to give us a first message about, particularly in French healthcare, to share your experience.
Thank you very much. Thank you very much first for inviting me to be part of this event. I work for the Defender of Rights in France, which is an independent institution currently led by Claire Redon, responsible for defending individual rights and freedom in 5 areas, including children's rights, the rights of public service users, the struggle against discrimination, and so on. The Defender of Rights has often alerted on the extent of racial discrimination in France and its systemic dimension. As you know, racism and discrimination remain widespread in France and affect the daily lives of millions of people, challenging their health trajectories and fundamental rights. So just to give you one number, origin, actual or presumed, is the second most significant ground for discrimination after gender, which means that 11% of individuals in France report that have experienced discrimination based on their origin or skin color over the last 5 years. So consequently, people of foreign origin or perceived as such are more exposed to unemployment, social insecurity, poor schooling and housing conditions, police checks, and health issues. So in the area of health, the Defender of Rights has stressed how racism and discrimination have a profound impact on people's health and access to health care, and notably for people of foreign origin, for Roma people, and for travelers. So she particularly insisted on 3 points, and I'm going to sum up them very quickly. The difficulties in accessing healthcare, difficulties in accessing the most basic public services such as water, and the overexposure to pollution and unsafe and unhealthy environments. And finally, we approach this issue, the consequence of discrimination and racism upon health, and in particular mental health. So to be very quick on the first point, foreigners encounter particular difficulties in access to healthcare and adequate social protection in France, particularly when they are in an irregular situation. There is an exception mechanism in French, which is called AME, State Medical Aid, which is reserved for foreign person in an irregular situation. and it offers less coverage than health insurance, the universal scheme in France. There are also illegal practices of France offices, which hinder the access to state medical aid. And finally, there are also discriminatory refusal of care. And we funded recently a study showing that doctors in France have discriminatory practices, refusing to see foreign patients benefiting from the state medical aid. Second point, the Defender of Rights also handled several complaints relating to situation of discrimination in the access to essential public services such as water, electricity, and household waste collection. As you know, the access to water and to a healthy environment is a human right, and for access to water, a fundamental right. And exiles, travelers, and Roma people face particular difficulties accessing safe and clean drinking water and running water more generally, whether in outing sites or in informal living spaces. Moreover, the Defender of Rights has also been alerted on the fact that outing sites or slums in general are mainly located far away from public services and very close to polluting equipment, such as waste disposal sites or sewage treatment plants. So in order to remedy this situation, the Defender of Rights made a series of recommendations, and maybe we'll discuss it later on. And final point, the consequences of racial discrimination upon health. So the Defender of Rights observe the dreadful consequences of discrimination and racism upon mental health in particular, whether in the studies carried out by the institution or in the claims it receives. And I'm going only to give one example. The 16th Barometer on Discrimination in Employment, which is realized with the International Organization of Labor, shows that 70% of the persons who have experienced racial discrimination in employment have undergone afterwards a period of sadness, tiredness, and depression, and half of them on a chronic basis. Thank you very much for your attention.
Thank you very much, and very interesting to hear the examples from France, how the person with responsibility for defending human rights has explored it and looked into it, and looked into both the impact on individual health, how people experience it, feeling it, but also looking at exposure to pollution and other environmental contaminants. We're going to keep going, and I'll come back with specific questions to you. But let me bring in Maricarmen Cortés from Fundación Secretariado Gitanos in Spain. And again, we'd like to hear the experience from your work, and particularly the areas where you have experience and what you'd like to share.
Hello, everyone. Good morning. Good morning, everyone. And thank you very much for the invitation to the European Public Health Alliance and the Office of the United Nations High Commissioner for Human Rights. I'm Maricarmen Cortés, coordinator of the Assistance and Guidance Service for Victims of Racial or Ethnic Discrimination of the Council for the Elimination of Racial or Ethnic Discrimination, CIDRE, which is currently the equality body in Spain. In my presentation, I will try to cover 3 points. The first, to make known in this case of Spain this service. Secondly, the most common situation of racial or ethnic discrimination that we deal with in our service in the area of access to health and health service and the impact on people. I try to give you some data. And thirdly, the main action that we carry out in the service to report this situation of violation of human rights. I want to start by saying that in Spain, fundamental rights, equality, and non-discrimination are protected in the Spanish Constitution, Article 14, and are regulated in the Law 15/2022, Comprehensive Law for Equal Treatment and Non-Discrimination. In addition, European and international human rights standards are enforced in Spain. Since 2019, the equality body in Spain is the, as we say, CIDRE, in accordance with Directive 2043 of Council of Europe, which provide that each member of state must set up one or more bodies responsible for the promotion of equal treatment for all persons free of discrimination for reason of ethnic or racial origin. The Council has the following competence: conduct an analysis and studied and publish independent reports, draft recommendation and proposal relating to equal treatment and non-discrimination on the grounds of racial or ethnic origin, provide independent assistance to victims of discrimination through a network or office through Spain. However, the main function of this CIDRE Council is to provide independent assistance to victims of racial or ethnic discrimination. This activity is carried out by the Assistance and Guidance Service for Victims of Racial or Ethnic Discrimination. The majority of report cases concerns discrimination that we register in our service is related but access to employment, access to goods and service, including housing, access to health, of course, discrimination in public places and security, as will incident to discrimination and hate crime, and the media and social networks. In Spain, access to universal healthcare has suffered setbacks that have mainly affected migrants and refugees. The majority of cases of discrimination in access to health registered by the CIDRE service affect migrants in an irregular situation and asylum seekers. In these cases, we found an excess of bureaucracy for the insurance of health cards and certification that enable access to health. In this sense, there are cases in which health centers deny health service to sick people, even in emergency cases. In other cases, people are treated in the hospital, but are later issues bill that they cannot pay. This situation has a direct effect because no matter if people are seriously ill, they prefer not to go to health service, knowing that the care will be denied or to avoid the bills. Even during the COVID-19 pandemic, cases of denial of COVID vaccination and medical care to irregular migrants and asylum seekers were recorded. Another common situation is that Roma people have been victims of mistreatment and prejudice comment against them in hospital by administrative staff, including doctors, especially against Roma girls. Comments such as that Roma women get pregnant and very young, as because this is part of the culture, among other stereotypical remarks. We receive also complaints about mention of the Roma ethnic groups in medical reports, and mention that is irrelevant for the purpose to the report and the only stigmatized. In general, the profile of the victim that we attend in our service are young people under 40 years old. Almost the same percentage as women as men. regarding their professional situation, the most of people are employed, and as 50% the people were in irregular situation, and even asylum seekers. The impact, the principal impact. Second, please. Sorry. The impacts on the health of the victim, we identified on mental health or even of physical health when there are injuries for racist attacks. For example, some cases, the Secret Service had deal with situation of bullying in educational center, where the psychological impact on children and adolescents are very serious, detecting that the longer they have been exposed to the discriminatory situation, and the bigger are damage and consequences such as depression, isolation, aggression, and even suicide attempts. In cases of violent racist attack, in addition to injuries to the body, which must be treated in hospital, there are also emotional impacts such as feeling of helplessness, anxiety, and depression. Above all, it is important to say that in cases in which the victim has reported to the competent authorities and there are no sanction or eradication of racist violence, the consequence of impunity have an influence on underreporting since the competent authorities are distraught. And this fact, in addition to leaving victims exposed to the repetition of racist situation against them, has serious consequence of the victim's mental health.
Maricarmen, are you coming to the end of your first statement?
Yes. I want to finally this intervention saying, but in the field of health, the strategy that the Secret Service carry out in this type of different kinds of strategies. It is very important to know you that in Spain, the equality body, which is this service, is not allowed, does not have jurisdiction to report cases of discrimination before the courts. That's all.
Okay. Thank you very much for sharing the experience of your organization and the information that you've gathered from the communities that you work with. We're now going to pass to Belgium to have the experience from Belgium, and immediately after Hans speaks, I'm going to be asking you a Slido question, and I'm going to be asking you, on a scale of 1 to 10, how much do you think national governments are aware about the link between racism, discrimination, and health? All the experiences that we've just heard, we're going to ask you whether you think that that information is making it up to the national level. But before we do that, Hans, let me invite you to share some experience. Of course, we are here in Belgium. It's a very diverse population. Tell us more about your role, and particularly intercultural mediation, how that can be used to tackle some of these inequalities.
Thank you. Is the mic on? Yeah? All right. So I'm working for the Federal Public Service for Health in Belgium, in charge of a unit that is called Intercultural Mediation and Policy Support Unit. And I would like to start with just some anecdotal evidence about what the situation is in Belgium in a way. Generally speaking, I think that this is true for most Western countries. We know that minoritized groups, it's a new word for me, actually they enjoy poorer health. So most studies will show you that. And that's one thing. There are what we tend to call ethnic health disparities. So they enjoy lesser health And the thing that is important for a unit like ours, which is working for the Federal Public Service, is that there are also, and that's very important, I think, ethnic health care disparities. So healthcare doesn't function as well for all groups, and that's a very essential point. And I was yesterday when I was preparing this session, I was just thinking about anecdotal evidence we have about this in Belgium, because we are, with my team, on a day-to-day basis in touch with hospitals and primary care centers and people working there, and in particular with the intercultural mediators we'll talk about later. But things that will be maybe difficult for ethnic minority groups, for instance, access to mental health care services. Many psychologists and psychotherapists don't like to work with them. They say it's impossible because there's a language barrier. They're culturally different. They are not motivated. They don't understand what it is about the mental health care service. What you see is that the people with an ethnic minority background, they will be on the waiting list forever. I mean, it is bad for Belgians, but those outpatients, it's very, very difficult. If you don't speak the language and you have an ethnic minority background, try to get a transplant. We know from studies, well, for instance, diabetes in Moroccan women in Belgium, or women of Moroccan origin, is about up to eight times as frequent as in Belgian women. Now, one of the consequences may be that you need new kidneys, you have complete renal failure, or you will be on dialysis for the rest of your life. It's very hard for these groups to get transplants, and it's not only true in Belgium. One academic hospital contacted us last week again. They say there's a big problem that 20% of the patients in need of a renal transplant don't speak the language, don't have a minority ethnic background, and we find it very difficult to help them. And in the end, very often they will not get a transplant. Not typical of Belgium, by the way. It's true for Australia. It's true for many, many countries. I think in vitro fertilization, very often in practice, you won't have it if you don't speak the language, if you are belonging to a minority group. I remember doctors saying, again, I'm an anthropologist, and my research in the past was mainly about the Moroccan community in Belgium. Doctors telling us self-monitoring for Moroccan women who have diabetes, we don't do it. They don't have the culture to understand what it is about. I mean, but this leads to quality of lesser care. Now, that's one important thing. So there are a number of fields, and this is certainly not a whole list, where there will be a difficulty of getting access to care that is badly needed. Thinking of mental health, which is a big issue, of course. We know there's more anxiety disorders, there's more depression in these groups, there's more PTSD, and the problem will be, and this combined with lower access rates for accessibility for these services. The other thing, of course, there is, and this is a very touchy subject, there is the whole issue of some care providers who are explicitly racist, who want to discriminate. So recently in one of the Brussels hospitals, 2 medical doctors were fired because they had been systematically saying to the nurses working with them, the blacks and the Arabs, we leave them on the side. Les Noirs et les Arabes, on les laisse à côté. There were a number of nurses, and it's difficult for them to report this because they depend on these doctors, but they were leaving the institution, they reported it, and 2 medical doctors have been fired. But when once I was visiting a Brussels hospital, there is a lady wearing a scarf from a Muslim lady who comes to the gynecological department, and I was doing observations there. And next to me is the secretary of the service, and she says to me with a big smile, the female gynecologist will not be available for this lady. So what does that mean? She didn't want this woman to have a female gynecologist because she said her idea was they should adapt themselves to the idea that a male gynecologist is just as well. Now, I know my wife, she prefers a female gynecologist, and she is not Muslim or anything. So, I mean, you just have to respect this. But these are these tricky, I find it very mesquin, we say in French. It's bad. It's really mean what they do. That's one thing. And the other thing, of course, is then once you get into the healthcare system, once you have access, there are going to be some major issues. I mean, one thing is, of course, time. If you don't speak the language and they will have to rely on an intercultural mediator or an interpreter, and you don't take more time for the intervention, you're in for trouble. I mean, this is not going to work. Because, of course, the patient, once he has the possibility or she has the possibility to express completely what his or her problems are, well, they're going to take this opportunity, and this is going to take more time. So you need more time, and this is an important thing in policy development. If you have a diverse population, and take the underground here in Brussels, and you will see it's very diverse, you will need more time. You have to take this into account. You have to take this into account because of linguistic barriers that will have to be resolved, cultural differences that may be at stake, and the health literacy. I think the lady from Holland who was speaking was very important what she said. Some groups, because of a low educational level of some individuals, may need much more explanation. They will need more time if you want to provide good care. Something that I find very interesting is the existence, and this was very popular in France in particular, of also nosological categories that were linked to certain groups. You had in Belgium, we also use the term, I've seen it in reports sent to general practitioners. The patient is suffering from the Malpartout syndrome. Malpartout means he has pain everywhere. Or the patient is suffering from the Mediterranean syndrome. What the hell would that be? Well, it doesn't mean anything. It means that the doctor can't find what it is about, and very often it is related to not taking the time to talk to the patient, not being able to talk to the patient, not trying to understand the context he is living in, etc., etc. Officially, the Mediterranean syndrome has now been abolished. So it has an article that says it doesn't exist, but it has been popular and in use for a long time. What we try to do in Belgium is we developed a large intercultural mediation scheme, which means that we have persons who have been trained to resolve the linguistic and cultural barriers, socio-cultural barriers, I prefer to call them, in healthcare. We have about 120 of them, and they do about 140,000 interventions in a year, which is of course a very low number. It may seem like a lot, but Belgium is extremely diverse, so we would need much more. And it clearly helps. We did a number of studies to improve the quality of care and to improve the accessibility of the care services. And also very important, and I think maybe even the most important thing, it creates confidence and trust in patients. I know you're probably aware of that, but there are many studies that have shown if you have a diverse task force in healthcare, this is going to increase the accessibility and quality of care to a diverse population. This has been very well proven. And what we see is once we have those intercultural mediators in place, that patients feel confident that they will be taken care of in the best possible way. As a Moroccan lady told me once, it is the presence of the intercultural mediator is the proof of the fact that they really want to help us. Because sometimes we're worried, because we are not liked as a community. And this is true. I mean, migrant communities are not popular in most European countries. Is this an answer to your question?
I think that was a very good answer, because you gave us some very concrete and practical examples of the experience, both overt, explicit and implicit, of racialized discrimination within healthcare and how important it is, and that what's needed as a policy response. So thank you very much, and thank you to Emilie, Maricarmen, and to Hans for those first messages. Now, I promised that I was going to ask you a question, and that's my trigger to also say I'm going to be opening the floor to questions for you. But first of all, let's just get a sense from you, from a scale of 1 to 10, how much do you think national governments are aware of the link between racism, discrimination, and health, where 1 is obviously unaware, and whether consciously unaware or unconsciously unaware, and 10 is they're really aware and they're going to try and do something about it. So we want to find out from you, where do you think the countries that you know best are on that scale? You know, are they aware that link between racism, discrimination, and health. We heard examples from both France, from Spain, from Belgium about, both data collection from Maricarmen. From Emilie, you told us more about how the defender of human rights is entering the health area and starting to understand what some of the challenges are. We heard from Hans, the observational studies that are being done within healthcare to try and see what are the pain points, where are the specific areas. So are these experiences reflective of the countries that might know best? And I'm looking at the results, and so far we've had about 35 people who voted, and it's significantly, the message is that it's at a very low level. So it's on a scale of 1 to 10, most of the people are saying it's between 1 and 4. Very few people up at the 10, 3% saying yes, governments know about it, they want to do something about it, etc. So I recognize it's a very simplistic question, but this is what we had wanted to ask them. Great, I said I was going to open the floor. Jackie, you're straight in there with a question. I know we also have a question online, and I'll come to you, Thomas, to that question, but I'm coming with the microphone, Jackie.
Okay, thank you.
I'm the walking question at the moment.
Okay, so Jacqueline Bowman-Busardo. My day job is head of policy at the European Association for the Study of Obesity, so health professionals. However, and I'll be talking a little bit about this a bit later as well, I'm now what I call a Brexit minted Belgian, living in Flanders, a minority of a minority of a minority, because I'm Guyanese, South America originally. Now, what I wanted to say is that in my personal volunteer capacity in Belgium, I actually sit on a couple of the UNIA, so the Belgian Inequalities Commission groups, one of which is related to data for to be able to measure discrimination and particularly racism and or on the grounds of health status in access to health services. And so I thought it was really interesting to listen, particularly to the Belgian example, because one of the big issues that we have is that essentially, if it's not measured, it doesn't exist. And in a lot of countries across the EU, actually, we're not specifically asked, and I have personal stories which I'm not going to go into, but we're not specifically asked we're not asked to make that linkage between what our ethnicity is and in terms of health data. And so it's very difficult. That's why I thought the results of the poll were quite interesting, because it's actually very difficult unless you start collecting data which can then be used as health data and to measure the discrimination therein. So it's the intersectionality. So I was just wondering, because I know the lady in Spain was also having difficulties with this, but reactions from other countries, as well as my colleague in Belgium, to say how this can be addressed in future.
Excellent, thank you very much. So a question there about making the link. If we don't collect the data, then the issue is effectively invisible to policymakers, and they therefore neither see it nor do anything about it. So Emilie and then Hans, would you like to respond on that? And then Maricarmen, I'll invite you as well to respond on this issue. How are we collecting the data?
Well, in France, it's quite a subject, collecting data on people's origin. There are different ways to approach this issue. You've got statistical studies, surveys that we realize in the Défenseur des Droits. Sometimes we do partnership with research teams. And we use different indicators to measure discrimination in access to healthcare, for instance. Just to give one example, we use sometimes the origin of the person, nationality, and a place of birth, and also for the parents and sometimes grandparents. But we use also an indicator which is what we call heteroperception, which means how do you think you're perceived by people, because we are forbidden to make like a referential this is good indicator to see how the person can be racialized and all the prejudice and bias that can interfere in the interaction and create discrimination. Just another example, we also do testing. I mentioned a study realized by an independent research team, but the Défenseur des Droits funded this study. And the results were published a couple of months ago, and they showed that the doctors have discriminatory practices and that they refuse beneficiaries from A and E. So, and this you can do it by the testing. So you send unemployment, but also an access to healthcare. And this is a good way also to measure racial discrimination in this particular field.
Yeah, thank you. I think, of course, we have in Belgium, like in most European countries, I think we have a national health survey, and we try to collect data also on minoritized groups in this. We will record nationality. We will ask about the nationality at birth, or I don't know what exactly they are using this time, but they will try to recover some persons who have an ethnic minority background, but who are not Belgian, who are Belgian citizens in the meantime. Of course, one of the problems with these national health surveys is that if you have, like in Belgium, it's about 10,000 persons who will be interviewed. Because of the relatively low numbers of ethnic minority groups, you're not going to be able to say very much about their health status and their use of healthcare services. So what you need is oversampling, and we don't do this actually, and that's of course a problem. And so we don't know very much about their health status, not enough. What is then registering racism and discrimination, or the experience of racism and discrimination in healthcare? We don't collect any data on that actually at this moment. But now Belgium developed a national action plan against racism, the NAPAC, which all European countries, and maybe even beyond, should develop. And we are lucky that our cabinet, the Minister of Public Health, he wanted to include a strand on healthcare. And so there's going to be a study by UNIA, which is an anti-discrimination body, on the experience of racism and discrimination in healthcare. And I hope that they will have enough budget to do this seriously and on a large scale. Because now what we see is that we have very few complaints from people, official complaints. And on the other hand, we have a lot of anecdotal evidence. But as my colleague from Belgium was saying, you need harder data in a way to convince people.
Thank you. Maricarmen, we have a specific question that's been submitted online about Roma, so I think that's best addressed to you. Thomas, can I invite you to read out the question?
Yes, of course. We have a question from Margarita Spasova, who is asking specifically about Roma, as Thompson said, and the question is there any research regarding Roma people access to healthcare in European countries, and especially using an intersectional approach, so considering gender as well?
Maricarmen, that's for you. You're mute. That's it. Go ahead. You're unmuted now. You should be able to speak.
Yeah, can you hear me?
Yes, we can.
Okay. In Spain, the most of the cases that we register in this service are for the victim as Roma people. But in Spain, there isn't a specific resource to Roma people. The resource in Spain, all people can access freely. But in the cases of Roma people, we register the intersectionality discrimination cases, because we have a lot of Roma women that suffer this treatment and discrimination in the access to health. So
thank you. So you have data from Spain, and because our question asked to try to get a picture across Europe, because of course we have Roma communities in a number of European countries. Are you able to give us an insight on whether there is data more broadly across Europe?
No, I'm sorry, but I have data. I haven't got this information now.
Okay, I know that this is now a number of years ago. The Fundación Gitano did do a report on access and experience of Roma in healthcare in a number of countries, but I don't know if it's been updated more recently. Let me see if there are more questions in the room. I'm going to come with you. Do you want to try speaking? Let's see if these green lights work. If you just speak in theory, we should hear you.
Hello, you hear me? Yeah. Okay. Quite weird, but hello, good morning. My name is Juliane. I'm the director of the European Anti-Poverty Network. So thank you very much for having invited us. I have a question to Hans. As you can see, I'm a Black woman, but I'm also a migrant, first generation migrant with the wrong passport because I belong from the South. And I'm also a daughter of 2 doctors. And of course, I've been sick here in Belgium. I've been sick elsewhere. And I also have daughters who are racialized and also need healthcare here in Belgium. But my question to you is, knowing as well how doctors work and how important is your service, how far can we go in a dialogue with doctor boards, with the Council of Board of Doctors, to change a little bit the mentality, the protocol, but also to stimulate new academic approach? For example, I've been taught my whole life that Black women can sustain pain because we're Black. And it's very difficult to address the question of pain level and the medical gaslighting that we as Black women face when you have to go to talk to doctors. So it's very important to talk about policies, but it's also important to change the structures. And I would like to know how far can your service go, because I was really surprised and really, I applaud what you are doing, but how far can we go in changing that structure that is composed of doctors?
I think it's extremely difficult. We don't have a lot of direct influence on them. And what strikes me is now that the theme of discrimination and racism is coming up. And also this conference, when I talked about it in my organization, they already felt slightly ill at ease. And now Unia is going to do this study about racism and discrimination. And I got a mail from someone from the cabinet said we should be careful that it doesn't become too condemning of doctors. And which in a way I understand, because of course many doctors and probably most of them absolutely want to provide good quality service. And it's a minority that is really actively racist and discriminating. But the others may not be aware of what they are, how their behavior and their attitude and certain prejudices may affect actually the encounter. So I think for us, I very much hope that this study is going to be well done and be not too condemning. I think that they have a point there. We need to create a dialogue with the profession. And also, I think very important with the institutions that train medical doctors, because I'm always so surprised that in the training of medical doctors and nurses as well, it's like a footnote, this diverse society. And I take the underground regularly here in Brussels. I live in Liège, I come from Antwerp. Everywhere where I go, I think if there's one thing that strikes you, it's the diversity. Take the underground here. And sometimes I think we should take all the politicians in the underground. They don't use it anymore. They have a personal drive. And it should be one of the main points in the curriculum. I used to teach a very long time ago at the University of Antwerp. I had a course on healthcare for migrants. It's not a good idea. It should simply be part of the curriculum. Everywhere there should be diversity present. And how are we going to deal with it? But so I'm afraid to disappoint you. We don't have very much influence. But I hope that this new study will open up the eyes in a way.
Thank you. I see we have a question at that. Again, I'm going to invite you to just speak, and hopefully these green microphones will pick up what you're saying.
Okay, I'm not under a green microphone. Should I?
Okay, you know what, I'll come to you.
Thank you. Good morning, everybody. My name is Rachel Hannons, and I work with the World Health Organization in Geneva. I'll make one slightly personal statement about this issue more generally. Our department, I work in the Department of Gender, Human Rights, and Health Equity. We requested that we have an unconscious bias training because look at me, what biases do I not know about? I mean, I know that I have many. Growing up in Canada, having the passports that I do, and the level of education that I do, all of the unconscious bias that I bring to my work, my policy advice, is something that I need to become more aware of. So I'd suggest that's something important for all civil servants to work on, all of us, but all civil servants. And then more generally to think about doctors. I have a background in both law and public health. I used to teach at the Institute of Tropical Medicine in Antwerp and the University of Antwerp. And I now teach also in London at the London School of Hygiene and Tropical Medicine, where we're trying to work on decolonizing our curriculum. But you hear the name of where I work, like the name of the Institute of Tropical Medicine in Antwerp, and that inbuilt stigma about tropical diseases that certain people get, certain communities have, and that people who come from other communities don't get. Completely wrong from the medical perspective. But the importance of starting early in schools with education, but also starting in medical schools with what we call at WHO diversity, equity, and inclusion training. It's better than nothing. It starts to get us somewhere. But the unconscious bias training as well is something that we all need as we live in diverse societies. I live in Brussels. I have for 20 years. So I take the metro on a regular basis, public transportation. I can't understand why politicians are allowed to be locked up in their cars, because I think it separates them completely from the people that they're supposed to serve. But I can't work on that. So I work on health. Thank you.
Thank you for that input. Yes, I can see a few more hands coming up. I'll come around. I'll start with you.
Good morning, everyone. My name is Irfan, and I'm a global health specialist, and I work for FRIANSA, which is Federation of National Organizations Working for Homeless. So I will go back to the discussion when we were talking about the data, and I understand, and I think everybody in the room understands how important data is to drive policy. But racism, discrimination, and when it comes to health for that group and marginalized population is also new for me. And I think that we need to really turn the tide upside down, because I know it's very sensitive, and sometimes when you want to gather the data, it's very difficult to actually get the real insights of people who are being discriminated, including the doctors, because sometimes they will not tell the truth, it's obvious. But I think we should also start, I will go back to Hans, because he really shared a very important testimonial where he was in an institution and where he had an experience that a Moroccan lady that said that they care for us. I mean, these kinds of practices should also drive policy, because I think there are a lot of examples where actually research didn't drive policy, it was practice which drive policy. So I think we need to really think in that kind of approach if we really want to make a difference. So that's actually, it's not a question, it's maybe a comment, and maybe I can ask Hans or anybody to jump in and ask that, could we see more of those approaches coming for the future of Europe, particularly in health? Thanks.
Thank you. I can see that you're already preparing our discussion this afternoon, where we're going to look at how do we take recommendations for change at a policy level, at a practice level. So thank you. These are really great inputs. I had a couple of hands up over here.
Thank you so much. Well, I'm jumping a little bit before my time on the topic of data. And just to share with you, we are kind of locked in a vicious circle. On one side, we are not developing sufficiently our statistical systems. Statistical systems that have to be developed in order to feed public policy, because public policy is not designed and defined if there is no sufficient data. Anecdotal data, as much as we share experiences here, will never feed public policy. I have one from my political family where the lady was, they made on member of my political family 4 attempts of in vitro in a Nordic country before recognizing that she has endometriosis because pain was not recognized as a symptom. No? So this will never go into policy until we start registering it. We are locked in the vicious circle of not developing data with the idea that data should only come from surveys and from the National Statistical Institutes. Those do not have power to record everything that happens on the ground in the hospitals, in the clinics. And by the way, health refers to public and private health sector as well that has to be regulated. So there we have the obligation, and I will speak later on OICHR methodology, from which you have a couple of photocopies shared with you, on the necessity to invest in administrative registries and administrative statistics. And from the international arena, you have recommendations that speak on the feasibility of using evidence-based data, expert data, data coming from civil society organizations, data coming from exactly what we call anecdotal evidence that can feed and influence public policies. So this is the only thing I wanted to mention, and also structural racism. The third committee, the Committee on Elimination of Racial Discrimination, starts the forthcoming recommendation on health, exactly speaking about the necessity to recognize structural racism. It's not that we are not racist by ourselves. Structural racism is the response of a system saying, I will not register data based on ethnicity. This is structural racism amongst others. Thank you.
Thank you, Mila. I wanted to comment and go back to Hans's comment about having to be careful not to be too condemning to medical doctors. And that only highlights the level of sensitivity of this topic and the level of the refusal to talk about it. Still, we're talking 21st century Western Europe. We still refuse to talk and recognize that there is an issue. So this resistance to talk is not only, it's not specific to medical community. It's not, so we thought in this room and online that the policymakers are aware of the issue for about 3.6 out of 10, but that translates to all of us. There is resistance to be talking about this topic also in civil society. How did we get there? Why is it not resolved yet? So I think there are ways to move this discussion forward. There are ways to raise our awareness in the medical community, among the public health, the public servants, among all of us, the civil society. It can happen through education, fine, but education system is slow. It will take ages. Yeah, so let's make sure that there is no course like health. How did you call your course? Health for migrants?
It was called like that at the time, yes. Yeah.
So let's make sure that there are no such courses as health for migrants, but to include all the minoritized and discriminated into this, racialized into the health curriculum, but it will take time. Yes, the idea of unconscious bias training is fantastic. Let's make sure that all of us who look like non-discriminatable, like myself, make sure that they take such courses. But I think we all, from where we are, need to up our advocacy game to make sure that this conversation is heard everywhere, all the time. So that was my comment. We need to make the change ourselves.
Great, thank you very much. I think this has been a really good start to our conversation, and a reminder that as we go through the day, we're going to be taking these examples and turning them into a call for action, a call for recommendations for policy change at European and national level. But I've allowed this to run a little over time, but I do need to close this panel. So can I say a warm thank you to Maricarmen joining us online, to Hans and Emilie here for sharing their experience nationally. And certainly, I think one of the issues we will be trying to unpick a little bit later is the fact that our healthcare community is both incredibly diverse, but not diverse at all. And that's to do with hierarchies of power and dynamics within the healthcare system, where you have a large number of nurses, particularly, who come from a racialized background, and yet at the sort of senior consultant, top of the pile, is overwhelmingly a majority population. And that this also affects the way that healthcare systems work. Let me now move on to our next panel. Thank